Thank you very much. Thank you for those kind introductions. I'd like to thank again the organizers for this kind invitation. So over the next few minutes, I'm going to take you through therapeutic inertia, the prevalence, consequences, and potential solutions. This is my outline. I'd like to get through the evidence for tight glycemic control, what's therapeutic inertia, what are the consequences, and what are the potential solutions. You know all this. In terms of tight glycemic control, there's abundance of literature. We know from UKPDS, ACCORD, Advanced, and VADT in people with type 2 diabetes, and DCCT EDIC for type 1 diabetes. In the short term, tight glycemic control leads to microvascular benefits, and on the longer term, in some cases, in particular UKPDS and DCCT, we get macrovascular benefits. VADT did see longer-term macrovascular benefits, which were not sustained at 15 years. And as you know, UKPDS has termed this the legacy benefits. It's bringing the HbA1c down, reducing the hypoglycemic burden for a longer period, which is going to reap the benefit later on in the 10-year follow-up of the UKPDS, with 24% reduction in microvascular complications, 15% significant reduction in myocardial infarction, and 13% reduction in all-cause mortality. How many people have seen this? Yeah, can you just give how many people have seen this one? Nearly everyone, yeah? How many people seen that blue circle on the right-hand side? One or two. Majority of people have seen this, but no one looks at this one. To me, this is the most important thing. That basically says to avoid inertia, reassess and modify treatment regularly every 3 to 6 months. To me, that's more important than whatever therapies that you're using. So this is the definition of therapeutic inertia. We changed it recently to failure to advance therapy or to de-intensify therapy when appropriate to do so. Now, we talk about intensification, but also at the appropriate time, it's also important to stop therapies and de-intensify, and I'll show you some examples of that. Previously, we used to think that inertia was prevalent when we came to insulin, or when we came to insulin intensification. But all the data now show that basically inertia is prevalent throughout the course of people with diabetes. So this is a large study of 80,000 people in the UK. On the left-hand side, you see people who are on 1 oral therapy. In the middle, people are on 2 oral therapy. And on the right-hand side, people on 2 or 3 oral therapies going on to insulin. All these patients had HbA1c above 7.5%. So we excluded people who had HbA1c below 7.5%. These were people we would suggest that it's appropriate to intensify therapy. On the left-hand side, when people are on 1 oral therapy, we wait a median of 2 years, despite the HbA1c being high, before we intensify. In the middle, if the people are on 2 oral therapies, we wait a median of 7 years before we intensify. And on the right-hand side, if the people are on 2 to 3 oral therapies, we wait a median of 6 years before we intensify. So this is showing that we are waiting far too long. What about the patients in India? This is some work we've been doing with Bansi. This was presented at IDF last year. This is looking at 18,000 patients, mean age 19 years, mean duration of diabetes 5 years. Clinical inertia or therapeutic inertia was prevalent in 73% of the population. And the predictive factors were people who were elderly and people who were on 2 or 3 oral therapies. Surprisingly, people on insulin, there didn't seem to be any inertia. So even in the Indian context, inertia is right. Looking at insulin, what stage do we initiate insulin? This is data from 16,000 patients in the SOLVE study, 10 countries. What HbA1c do we initiate insulin? The mean is about 9%. As you can see, there are variations. 8% in China and about 10% in the UK and Turkey. UK has always been quite poor initiating insulin. So initiation is late, but then intensification also doesn't occur. On the right-hand side, what you see here is the Julio Rosenstock study. a 52-week trial, treat to target trial, and what you can see is you can get to insulin levels up to 0.78 units per kilogram reasonably safely. This is a global study. But when we look at the real-world setting in this study, the insulin initiated at 0.1 to 0.2 kilograms. Doesn't matter what level we started. What's important is that we also need to titrate. So in some countries, they started at 0.15, but by 24 weeks, they got to 0.2, and there wasn't any titration occurring. While in the UK, we start late, but then titration occurs quite significantly. And this is what you see in terms of HbA1c reductions. This is the units per kilogram here, about 0.15 units per kilogram. Intensification occurred up to 12 weeks, and after that, there was leveling, so no intensification after that. You get the corresponding reduction in HbA1c from about 9% to 7.8%, and again, you get leveling off. These patients were not getting any hypoglycemia at all. Despite that, we do not intensify therapy. What about when we ask physicians, what's your goal, and will you get to that within 3 months? So this is asking the physician that what is the goal for the patient, individualized target. In this study, we looked at 3,000 patients in 28 countries. So when the physicians set their own goal, at 3 months, only 27% managed to reach that goal. So even when we say this is the goal I want to reach in 3 months, we don't tend to do it. We only reach it for a quarter of our patients. And about the same amount reached that level without any hypoglycemia. This is a study we looked at 40,000 patients from 5 European countries and US country. And again, as you can see, this is the baseline HbA1c for the 5 countries at which we initiate insulin, this being UK at around 10%, and these are the other 4 countries, Italy, Spain, Germany, and France. As you can see, at 3 months, 6 months, 12 months, 24 months, we do not get to a target of less than 7.5%. Waiting far too long and then not intensifying. What this study showed that the good marker for whether you're going to reach your target is 3 months. If you don't get to your target at 3 months, you're 4 times less likely to get to that target and maintain that target at 24 months. So we've got inertia at orals, we've got inertia at insulin. What about insulin plus? When patients don't get to target on insulin, we have to either start a premix, put them on a basal bolus, or put them on added GLP-1 receptor agonist. So this is exactly what we looked at in about 12,000 patients. Again, HbA1c above 7.5%. And what we see in this study, only 13% of patients had intensification, either with a basal GLP-1 receptor agonist or a premix. 32% of people stopped their insulin. And it took a median of 3.7 years from the time of initiation of basal insulin to intensification. Again, waiting far too long when basal insulin has failed as well. When we bring it all together in this systematic review of 54 studies, basically therapeutic inertia is an international phenomenon. Every country we looked at, 54 studies, everywhere we're waiting far too long, anything from 2 to 4 years for orals and anything from 4 to 6 years for insulin. What about looking at quaternary prevention? We know primary prevention, we know secondary prevention, and tertiary prevention. Quaternary prevention is interventions that protect a group at risk of over-medicalization. So this is when we need to de-intensify therapy. This is data from Lipska from the US, looking at people, huge study, looking at patients who were healthy, complex, or complex and they were poor in terms of frailty, etc. What you can see is that the proportion of patients who reach a target of less than 7%, 7 to 9%, and more than 9%. There is no difference. So whether patients are complex and frail or whether patients are healthy, there is no difference in terms of the proportion meeting those targets. In terms of patients who are on insulin, on sulfonylurea, again, the proportion of patients on insulin and sulfonylurea, no difference if you look at it, whether they were complex or they were relatively healthy. So we're not determining the patient in front of us and then thinking that we need to de-intensify therapy when it's about right to do so. This is data from the UK. We looked at nearly 4,000 patients. The median age was 78 years. 48% had CKD. And in terms of the proportion of patients who were prescribed sulfonylurea and insulin, it was about 35%. So again, when we look at sulfonylurea, insulin, and sulfonylurea and insulin, the proportion who had a target of less than 7.5% was very, very similar. Again, we're not de-intensifying. A person aged 75 years of age, they don't have much to gain by tightening their glucose control compared to someone who doesn't have diabetes. That's the stage we need to think about stopping therapy for certain patients. So, what are the consequences of inertia? The only way you can do this is by a randomized control trial. Unfortunately, ethically, this wouldn't be approved. You cannot withhold therapy in some people and add therapy in the others. So the only way you can do this is by doing retrospective analysis. So this is exactly what we have looked at with other people as well. This is a really nice study from the US looking at consequences of inertia, and this is retinopathy. So these were patients who, some of them had intensification at the appropriate time, so no inertia, compared to those who had inertia where tight target-driven therapy wasn't given. And what these studies showed that there was just an incidence rate for diabetic retinopathy progression was 5 times higher in those patients who had inertia. This is a study Sanjoy Paul and I did. Sanjoy Paul, you probably don't know the name, but you should do. He's from Calcutta. He's the one who did the UK PDS study, the analysis of the 10-year blood pressure and the HbA1c study. He did all the analysis for that. So Sanjay and I worked quite a lot together. So we looked at exactly the same, a UK PDS type cohort, newly diagnosed with type 2 diabetes, and looked at the proportion of patients who had HbA1c below 7% within the first 12 months. And this was about 74% of the population. And this is the population we would call not having inertia. But there was 26% of patients who had inertia. They did not have tight control within the first 12 months. And what we see here is at 5 years, in those who had inertia, there was a 67% increased risk of myocardial infarction, 51% increased risk of stroke, 64% risk of heart failure, and composite cardiovascular events of 62%. So you heard the legacy benefits from UK PDS. This is what we've described as dysglycemic legacy, which is driving the long-term complications. And this is the latest study, a really nice study from the US, looking at mortality, association of inertia with mortality. And what they looked at was HbA1c of 7 to 8% or greater than 8%, and how long we wait before we intensify therapy. So if we look at this here, 7 years of inertia with an HbA1c of greater than 8%, there's a 64% increased risk of mortality. 3 years of inertia with HbA1c above 8% before we intensify, there's a 37% increased risk of mortality. So all these data showing that inertia is associated with microvascular complications, macrovascular complications, and mortality. What are the potential solutions? There are a number of solutions, but it's quite complex. Inertia isn't one size fits all. These are the barriers, and these are some of the reasons for inertia. And I'll take you through some of them. We worry about hypoglycemia. We worry about impaired quality of life. Patients don't adhere to treatment. There's financial restrictions. There's beliefs about patients' competence, resource use, risk of patients with comorbidities. The regimes are very complex. We worry about weight gain. Patients don't have education. And there's patient perceptions for things like insulin and poor outcomes. So complexity, definitely an issue for healthcare professionals and patients. This is looking at how complex the therapy regime is and the adherence. So if people are on a tablet that you take once a day, the adherence is about 80%. If you have to take tablets twice a day, adherence goes down to about 65%. If a tablet needs to be taken 3 times a day, then adherence goes down to 40%. So we want to make things that are easier for our patients to remember and not be as complex. As you can recall, patient with diabetes, they'll probably be on about 10 drugs, both diabetes and non-diabetes drugs. There's also this called the efficacy to effectiveness gap. What we see in a trial setting, we do not see that transferred into the real world setting. So this is a really nice study from the US. We see with GLP-1 receptor agonists in a trial setting an HbA1c reduction of 1%. When we translate that into the real-world setting, we see an HbA1c reduction of about 0.5%, half what we see in the trial setting. And this study did some modeling, and they thought that about 75% of this efficacy to effectiveness gap is because of poor adherence. The other 25% was because the baseline characteristics were different in the trial setting compared to the real-world setting. This is very difficult to measure adherence. The only way you can do is pill count or observe patients, which is not practical in the real-world setting. Prashant Patel, a colleague of mine in Leicester, they've just developed the first urinary objective measure assay for adherence. We can measure about 60 metabolites in the urine. So this is the first study looking at an objective measure of adherence. We did this in about 200 patients. What we see, these are all the therapies that the patients were on. Metformin, the adherence seems to be good. Sulfonylurea, adherence about 80%. GLP-1 receptor agonists, adherence 70%. Statin, adherence just under 70%. And these are the blood pressure drugs, ACE inhibitors, ARB, calcium channel blockers, beta blockers, and diuretics. So as you can see, these patients are on complex regime, and adherence is poor. And when we look at the adherence, the HbA1c, albumin-creatinine ratio, and lipid profile was significantly higher in those patients who were non-adherent. And overall, about one-third of the patients were non-adherent to at least one drug. Non-adherence is an important aspect because non-adherence from this systematic review shows that if people are more adherent, they have a 30% reduced risk of hospitalization. If people are adherent, they have a 10% reduced risk of all-cause mortality. So we shouldn't just dismiss adherence that simply, because it does have huge consequences for the patients. Hypoglycemia, a major issue. This is data from the HAT study. What happens when patients have a hypoglycemia? They either reduce insulin dose or they miss an injection. But if you look at the South Asian context, this is, as I said, this study was 24,000 patients, 24 countries. And when we looked at South Asians, they're the worst in terms of reducing insulin dose and especially missing injections. Southeast Asia, 30% of people with type 2 diabetes will miss an injection, and 20% with type 1 diabetes will miss an injection following an hypoglycemic episode. What are the interventions to overcome inertia? Again, this is a talk in itself, but there are a number of studies that have been done looking at education programs, motivating and supporting patients for self-management, trying to improve adherence, trying to improve adherence to guidelines by healthcare professionals and giving them personal feedback, and developing quality measures and improving effective information systems where you get a prompt to get a healthcare professional to do something about it. This is a study one of our PhD students did, Winston Crasto. This is a type 2 stenotype study, people with type 2 diabetes and microalbuminuria. So this was a multifactorial intervention, and what we looked at is 18 months. So this is the control arm at 18 months, no change in HbA1c. In the intervention arm, there was about a 0.5% reduction in HbA1c. So significant reduction in HbA1c as well as blood pressure and lipids as well. To our surprise, what we found was in the intervention arm, despite getting the HbA1c down by 0.5%, and these were patients who were complex, went on to insulin, there was no hypoglycemia, severe hypoglycemia. In terms of moderate hypoglycemia, there was a reduced risk in those who reached the target compared to the control arm. And the one reason we think this happened is because all the patients in the intervention arm had an education program how to recognize hypoglycemia and how to manage hypoglycemia. So education is an important aspect of therapeutic inertia. This is a stepping up trial by a friend of mine, John Furler, trying to improve insulinization in a randomized controlled trial setting in Australia. So we know that healthcare professionals are the biggest barrier in initiating insulin. So this was trying to upskill healthcare professionals in a primary care setting. And what they looked at was the HbA1c reduction in those practices who had empowerment to initiate insulin with the nurses and the GPs. There was a 0.7% reduction in HbA1c. And overall, the proportion of patients who were likely to get onto insulin was 8 times higher in the intervention group. So in a primary care setting where majority of these patients manage, if we empower them, if we give them education, we are likely to get more patients onto insulin. Combination therapy, you mentioned about adherence. Combination therapy certainly is one of the ways to reduce inertia, because we can achieve therapeutic goals. We can use small doses of complementary therapies so that we reduce the side effects of the therapies at full doses, and certainly been shown to improve compliance. Adherence to insulin, this is a systematic review that we and others have conducted. Adherence to insulin is about 43 to 80%, but again, educational programs have been shown to improve adherence and improve outcomes as well. So in summary, type 2 diabetes is a progressive disease, and early preventative interventions and tight glycemic control is associated with long-term benefits. There is a major efficacy to effectiveness gap in terms of we're not getting to target for our patients, and as I've shown you, there are many barriers of translating evidence into improving outcomes in the real-world setting. And because it's so complex, different solutions are needed to overcome inertia, and we really need to try and individualize not just the therapeutic targets for our patients, but also how we educate our healthcare professionals as well. Thank you very much for listening. I'll just finish by what patients really want for their treatment. We talk about patients all the time. They're the center to our care. When we look at patients, the problem they have is they worry about hypoglycemia, late microvascular complications, lifestyle restrictions. They have emotional effects of this: frustration, fatigue, anxiety, and loss of control. They want us to reduce their risk of hypoglycemia, and their long-term complications. And they want treatments and devices that match individuals. But what do patients really want? Ultimately, they want, like me and you, to live a happy and a long life. So what we need to do is, from treatment, rather than seesawing around with inertia, we need to get the HbA1c down below 7% and keep it at 7% or below for as long as possible until we feel that it's not appropriate to do so. Thank you for listening.